In the next few minutes, I'm going to discuss the use of intravascular ultrasound and its role within the goal of optimally treating patients with peripheral artery disease. These are my disclosures. So I think we all recognize that angiography has significant limitations. In these examples here of angiography of the SFA segment, you can see areas that by angiography appear to have mild to moderate disease, but by IVUS have evidence of severe focal stenoses. And there are a number of reasons for this. A few of them are that we tend not to use biplanar imaging when we do lower extremity intervention in angiography. But the reality is that angiography significantly can underestimate and not give significant diagnostic information regarding lesion morphology and characteristics. So what is the rationale for using IVUS in femoral popliteal imaging? Well, I think there are three main reasons. The first is to optimize technical or clinical outcomes. This can include optimizing the reference vessel diameter as well as the luminal gain with angioplasty or other devices. Importantly, IVUS can help identify and characterize dissections post-angioplasty with regards to subsequent treatment of those dissections and optimizing patency. Second, IVUS has an important role in helping define the disease etiology, and this can direct subsequent treatment. Examples of this include identifying thrombus, the extent of calcium, as well as mixed plaque morphology, which might use to differential use of atherectomy or other adjunctive devices in order to improve the interventional treatment of a lesion. And then finally, a specific example of IVUS use is to facilitate interventional treatment. These include image-guided crossing devices, including the Pioneer device, which can assist with IVUS-guided reentry, as well as OCT-guided crossing as well. So let's talk about optimizing outcomes in residual stenosis. This is an example of an 82-year-old man I treated recently who had severe foot pain and rest pain, as well as ulcerations at his great toe. He was told they need a below-knee amputation, and this is what his baseline angiogram looked like. You can see he had diffuse disease of his femoral popliteal segment with an occlusion at the popliteal artery and reconstitution in the anterior tibial artery. I was able to cross into the anterior tibial with a gladius wire and performed scoring balloon angioplasty across the distal popliteal and anterior tibial artery, as demonstrated here, followed by further scoring balloon angioplasty with really quite adequate runoff to the foot, but interestingly, there was significant residual gradient on pullback across the distal SFA that on angiography looks really quite mild and likely would not warrant treatment otherwise. But on IVUS, this demonstrated that this was a 6 millimeter reference vessel and the residual stenosis was in the range of 50 to 60%. This was actually associated over this length with a 50 millimeter residual gradient. So as a result of the IVUS imaging, I then performed further drug-coated balloon angioplasty with a 6 millimeter size balloon with the final result and no residual gradient. And I think, while this is not a difficult lesion to treat, it emphasizes that if we use angiography alone, this may be one mechanism why we see early failures with procedures, where if this lesion was not treated during the procedure, there would be a residual gradient which might lead to long-term downstream occlusion and the need for reintervention. So I think this is a specific example where IVUS can help optimize both the procedural and long-term outcomes. So what about optimizing outcomes with regards to dissection identification? Well, we had a great talk by Dr. Gray earlier with regards to TAC-assisted angioplasty. And the reality is that dissections are essentially the mechanism of all angioplasty. And angiography alone also underestimates dissection severity. A recent publication by Nick Shamas and colleagues demonstrated that by angiography in areas where dissections are not apparent, you can still often see evidence of significant disruption of the media and in some cases the adventitia, as shown here in this example where there's no apparent dissection on angiography, but involvement of a dissection extending into the media. And as a result, an IVUS-based dissection classification scheme has recently been proposed called the iDissection scheme, which takes into account the depth of the dissection in the intima, media, or adventitia, and whether that dissection has a circumference of less than or greater than 180 degrees. So I think classification systems such as these need additional data, but they provide some initial information with regards how to optimally classify and potentially treat such patients. So with regards to etiology, IVUS also provides very important information with regards to the plaque characteristics. This is a patient who had mottled toes. You can see evidence of significant dampening at the popliteal waveforms and in the infrapopliteal segment. She had evidence of a subtotal popliteal occlusion on angiography, as demonstrated here on magnification. And the question becomes, what is the etiology of this case? Is this embolism? Is this thrombus? Is this calcific disease that has progressed? It's not apparent on the angiography, but on IVUS it was clear that the patient had a proximal disruption of the plaque at the proximal lesion edge, consistent with a plaque rupture and a critical stenosis distal to that. You can see that this lesion does not have significant calcification. It has some potential mixed thrombus as well on top of this area. So this is a type of lesion that I think is very reasonable to treat with laser atherectomy. We used laser atherectomy followed by drug-coated balloon angioplasty, which demonstrated minimal residual stenosis. And then finally, with regards to etiology, I think we all recognize that calcium is a major limitation with regards to outcomes of current endovascular therapies. And a recent publication by Fujihara et al. In the Journal of Endovascular Therapy entitled The CODE Study, I think provides a lot of new additional data with regards to optimal treatment of calcified lesions. This study involved 130 patients with de novo SFA lesions. IVUS was performed in all cases, and lesion calcification was assessed by IVUS as well as using the PAC score. These are examples of cases where patients had significant calcification in an arc greater than 180 degrees before and after POBA and before and after stent implantation. And interestingly, the post-procedure minimal lumen area in the setting of no calcification was significantly greater. I think we all recognize that when we have calcified lesions in the SFA, that achieving adequate luminal gain is difficult, and this is some IVUS characterization of that. Interestingly, when they dichotomize patients with calcification as having a calcification arc less than or greater than 180 degrees, is really the patients who had an IVUS calcification arc greater than 180 degrees that had the highest restenosis rates. So I think these are additional data that can help us develop optimal therapies, perhaps the use of specific atherectomy devices in these cases of higher calcification arcs could optimize both the acute and long-term outcomes of such patients. So in conclusion, IVUS adds important information on optimal vessel sizing, identification of dissections, and identification of residual stenosis. The routine use of IVUS can help direct the use of adjunctive therapies, for example, atherectomy based on the extent of calcification. And the reality is that while these are all instructive case examples and cohort studies, we do need more data on whether routine IVUS use can improve the patency of infrainguinal interventions. Thank you.